All right, guys, it is April the 18th, 2026, Saturday, 1 p.m. We're starting our next lesson for our studying for TMC. For those that are getting ready to graduate, for those who have already graduated, right, that maybe graduated last year or a couple years ago, trying to go back and get that RRT and meet that high cut score. Okay, so as before, we'll be going over some lessons that are pulled from the TMC, and how they will relate to making the best choices when you're making choices on your answer sheet, right? So it's not designed to reteach respiratory, but it definitely will go over some of those basics so that we can remember some key terms that you'll be seeing and to brush up on so that when you see them again on the test, you know exactly what to put. Because remember, they try to put a lot of fluff in the question, and they may throw some terms out there that don't mean anything, that have anything that pertains to that question, and they use it simply to throw you off. Okay, remember that you can do process of elimination. That's always a good strategy when taking tests and try to get rid of one of the choices for sure, right? Again, you'll have multiples, and sometimes it'll have is the answer one and two? Is it 1 and 3, 2 and 3, 1, 2, 3, and 4? Those like that when you have those multiple choices. And so if you can throw out one of the selections, then you can definitely help yourself in your end answer, right? So if you know that one is not couldn't be in it, then you can count out any of the choices that have one in it, right? So that type of thing. So that's what I'm not trying to go back to the beginning with you guys, but it is important to brush up on some of those things that you learned when you first got into school that you may not be using a lot, but they will show up on the test. All right. So like I said last time, if I believe we ended with auscultation, which talked about the breath sounds and the egophony and all of those things. And the recording was also sent out. So if you didn't get the recording, then just put a little message in the chat that I didn't get it and leave your email, and I should be able to email you from here the recording. Um, Also, I said if there was any questions on that, we would go over that. Today, I'm definitely going to start right into cardiac assessment, like we talked about. We're going to discuss some anatomy and electrophysiology, how the cardiac examining the parts of the heart, things like that, just brushing up on those things. Pathophysiology, right? And do a little bit of those heart rhythms and heart guessing the heart rates and things like that by using your boxes and all of that. So hopefully I will stop long enough, short enough for us to do a simulation today. As I said before January 2027, you'll be the test that you take will be the questions and the cliniciums, right? And excuse if you hear traffic go down the street. I'm in my garage today, but it's usually a really um, slow day, so it shouldn't be much traffic. If I say something that you don't hear or you need me to repeat, just raise your hand or come in and say, "Hey, can you say that again?" or whatever, and I don't have a problem with that. So we'll try to do some simulation. So because after 2027, the simulation is going away as far as on the test, so you won't have multiple choice, and then you also have clean sims and 2027. So before them, and that doesn't mean that the clean sims information is going away. Some people say it might even be harder when you're not doing it because they're going to try to make those questions, bring all the clean sims into multiple choice form questions, which they may try to jazz it up and make it kind of hard. Okay. And so, to each his own, but I advise everyone to go ahead and take it after we get through most of the things that are on this syllabus, right? Of things that I plan on doing with you guys. That's what I'm trying to go in order. Wherever we leave off is where we pick up. So take notes, and a lot of those test taking strategies and tricks. Keep up with those so that as soon as we're done, go ahead and schedule your test. And the school Northwest is going to help you pay for that first test that you take, right? So that's a great incentive to do that. I came to the campus the other day, saw many students there. We did talk about a lot of benefits of going on and getting that RRT. So we can talk about that a little later. Let's go ahead and jump into it. If there's no questions from last time, again, if you didn't get the recording, then I just put your email in the chat of this chat box, and then I'll see it, go through and email it to, put your email in there. All right, so cardiac assessment. So I'm going to share my screen. Move this out the way. All right. So heart anatomy, circulation, and electrophysiology. There are going to be some key terms just to kind of brush up on those things to remember. Oh yeah, that's where that is. The blood flow through the heart is vital for us to know that, right? You need to know and brush up. Remember all the structures and compartments that the travel of the blood takes on its journey, right? And so we'll go over those things because you may have a question that identifies one of these structures, and if you don't know where that is, you might not be able to answer the question correctly. And every point matters. Okay, every point matters. So let me pull this up a little bit more. All right. Let's see, do I need to make this a little smaller? Too small. Okay. All right, so cardiac anatomy, understanding the basic anatomy is very important of understanding hemodynamics because we're going to get into that by the end of this session today. We should be able to go through these heart rhythms, remembering those things, and then get into hemodynamics, which is a big part of any exam that you're going to take and a big part of your career, right? When you get into ICUs, hemodynamics is a monster, right? But it's a fun monster. If you can tackle it, then it's perfect. You don't have anything to worry about. That makes you understand every aspect and every function of the body if you can understand the cardiopulmonary aspect, right? So cardiac anatomy, we start off with these structures here. We have 4 chambers, and remember, and there's 4 valves, right? As far as the chambers, and this is a photo here. But as far as the chambers, you have the right atrium, right ventricle, left atrium, left ventricle. So I'm going to show that as well with my little diagram that I have right here. I hope everybody can see it. Let me make sure. Can everybody see this clearly?
Yes.
Okay. So this is the just a little example of the heart here. Maybe it's better if I put it on here. And so we're gonna go over those chambers and then those valves as well, right? And the chambers, the valves, and the branches, right, which we call made the vessels. All right, so just looking at that, the blood returns. Remember this, and make sure you understand this and remember this, so that you will have questions that may ask you what is the next stop for blood when and after it leaves the this or the that, right? And then so you got to know, oh yeah, that's this chamber or this valve or whatever. Be very careful because they're going to be very specific, right? So the blood returns to the heart from the body via the inferior and the superior vena cava, right? Inferior and superior vena cava, they dump into the left atrium, right? They go down through the tricuspid valve into the right ventricle, right? Now, did I say right? I meant right atrium. Tricuspid valve into the right ventricle, which is this one here, small. See how it's much smaller than the left ventricle, right? Then it leaves the right ventricle and goes through the pulmonary valve, right? Into the pulmonary artery, okay? And then to the lungs, right? Picks up the oxygen in the lungs, of course, comes back to the heart via the pulmonary veins. And remember, there are two sets of pulmonary veins on the back, these red ones here, right? Both of them dump off into the left atrium, right? And then they leave the left atrium through the bicuspid valve, right, into the left ventricle. And remember that this is the left side or the systemic side of your circulation. The right side is your pulmonary side, right? So after it leaves the left ventricle, it then goes through and it's hard to see it up in there, but that would be inside there is the aortic valve, right? Into the aorta, which is this one here, and then to the body. Okay, that process you have to have down pat. Okay, and this is the cross section of it here. Now they won't ask many questions about your carotid arteries and carotid veins, right? But you do have carotid, the common, not the carotids, but the coronary. You will have some questions. They may talk about stroke. They may talk about heart attack, STEMIs, all that kind of stuff will be dealing with, when you're talking about the STEMIs, it will be dealing with your carotid, not carotid, I keep saying that, but your coronary arteries and coronary veins, right? So your coronary arteries are your red structures here on the outside of the heart, right? And your coronary veins are those blue ones, which are deoxygenated, okay? And so that's how the heart itself gets its blood and gets rid of its used blood back to the circulation, right? And so that is the circulation of blood through the heart. Blood returns to the heart from the body, right, via the inferior and superior vena cava, which is on the paper in front of you, dumps into the right atrium, right, goes through the tricuspid valve into the right ventricle, right, then through the pulmonary valve into the pulmonary artery, and then to the lungs, right? Gets oxygenated in the lungs, comes back to the heart via the pulmonary veins on both sides there. They're red now, it's oxygenated, right? Dumps into the left atrium, goes through the bicuspid valve into the left ventricle, and then through the aortic valve, which is up inside of there. I hope you can see it, but up inside of there is my aortic valve, right, into the aorta and into the body again, okay? Very, very important that you have that. So you need to know your four chambers, which is right atrium, right ventricle, left atrium, left ventricle, and your valves are your tricuspid, which is on your right side, your mitral valve or bicuspid, right? Those words are interchangeable. So you might see bicuspid, you might see mitral, but those are on your left side, okay? And the way to remember that is you try before you buy. If you go to the store, you want to try on clothes before you buy them, right? So on this side, on the right side, you have your tricuspid valve, and on the left side is my bicuspid or mitral valve, right? We try before we buy. All right. So I don't know if that'll help you, but hopefully that can help you remember which one is on which side. Okay. You may have a question that talks about some kind of stenosis or issue with the mitral valve, right? And then what kind of situations or disease process might you see with that, right? With that, if I know if it's a bicuspid or mitral valve problem, I'm thinking left heart side problem, right? If I'm thinking tricuspid valve stenosis or some type of issue, then I'm thinking right side heart issues, COPD, cor pulmonale, all those ways to get your mind thinking on which side, because if you don't know which side you're dealing with, there's no way you can answer the questions correctly, okay? So then you have we talked about those branches, which are your pulmonary artery. Why is this? Your pulmonary artery, right? Your pulmonary vein, your aorta, superior vena cava, and inferior vena cava. Okay, that is the blood flow through the heart, right? Your main chambers, valves, and branches. Make sure you remember those. Again, this is here, so you go back and look at the recording. If you want to see it more closely here it is. Okay. Any questions on that before I move on to the next page? All right.
No.
Okay. So circulation, I'm sorry. Systemic circulation, remember, is the left side, right? Systemic circulation carries the oxygenated blood away from the left side of the heart to the body, okay? The blood is often depleted of oxygen and returned to the right side of the heart. So it goes from the systemic or left side of the heart to the body to be used at the tissue level, right? And then that's when we have internal respiration, right? Remember, external respiration is between the outside air and the lungs. When you breathe in and out, ventilation gives us external respiration, right? Gas exchange between outside and in the lungs, right? But after the blood goes to the heart and then comes back from the lungs to the heart, right? It is now oxygenated and ready to go to the body. When it goes to the body, it's going to go all the way down to your tissue level, and gas exchange will happen at the capillary and tissue level, right? That's internal respiration, okay? So just keep that in mind. The systemic circulation is a higher pressure system than the right. Now, pulmonary circulation, just remember that pulmonary circulation carries the deoxygenated blood away from the right side of the heart to the lungs, right? So that deoxygenated blood that you used up during internal respiration is now used up. You got a PaO2 of about 40 or so, right, of venous blood coming back to the right side of the heart because now it needs to get oxygenated again. So it has to go through that circuit system again from the inferior and the superior vena cavas, dump into that right atrium, go through the tricuspid valve into the right ventricle, through the pulmonary valve into the pulmonary artery, and into the lungs, right? Picks up that oxygen in the lungs, returns to the heart via the pulmonary veins, right? And both sets of pulmonary veins dump into the left atrium, goes through the bicuspid or mitral valve into the left ventricle, then slides up through the aortic valve into the aorta, and then back to the body. Some goes up the common carotids to the head, and others go down the descending aorta right down the middle of your body, okay, and branch out through all of your other arteries, your radial artery, your ulnar artery, your brachial artery, right? Your dorsalis pedis, all of those femoral arteries, all of those things are oxygenated blood. Okay. Now, but that's on the left, the left side. But the pulmonary circulation is when it carries that deoxygenated blood away from the right side of the heart to the lungs so it can get reoxygenated. Okay. Pulmonary system, it should be a low pressure oxygen system, low pressure. And it makes sense because the PaO2 is going to be, or PVO2 is a lot lower on the pulmonary side or the venous side than it is on the arterial side, right? So all those pressures have a weight, right? Remember Dalton's law. All those things matter. All that, I used to call it the gumbo, right? Gas gumbo. All right. So that just kind of shows you some things right here. I don't have a pointer on my Zoom. I'm still learning my Zoom, guys, but I don't have a pointer, but I will get one. But this is your aorta here. This is your pulmonary artery, and it kind of breaks off. This is the left pulmonary artery, then the right side pulmonary artery. Still one pulmonary artery. The test won't ask you anything about a right pulmonary artery or left pulmonary artery. It's just simply going to be the pulmonary artery, right? So, and then thinking about that, as we get to these, when you start critical thinking, they may have some drugs, right? That's listed on your answer sheet to treat different things. So like if we're having pulmonary hypertension, that means blood can't get through this pulmonary artery, right? This pulmonary artery's tension is really tight. And so blood can't get through. And if blood can't get through to get to the lungs, then it's going to return back to the left side deoxygenated because it can't get there, right? And that's when you have shunting problems, right? And so there's drugs that help dilate this pulmonary artery so that blood can easily get to the lungs to pick up the oxygen, right? And so does anybody remember some of the drugs we use for pulmonary hypertension? Say it again.
Nitric oxide.
Nitric, okay. Nitric will dilate the pulmonary artery. What's something else that you may have heard of?
Isn't it like a phenodrine or some kind of what is it?
Flowland. We use Flowland. Flowland will dilate the pulmonary artery.
Oh,
Um,
Levophed?
no, Levophed is for blood pressure. That's for raising the blood pressure. Okay. But Viagra, right? Viagra was of course, Viagra was originally made for pulmonary hypertension, right? The side effects was helping patients with ED, and it was so much so that they've changed the main focus of Viagra to erectile dysfunction. Okay, but it was made for pulmonary hypertension, and it
Okay.
it by releasing and helps dilate that pulmonary artery here, so that blood can safely get to the lungs. Okay, so it's just kind of showing you again. Say what?
Does
You broke up a little bit. Say what? You might be muted.
I think he said oxygen.
Oh, okay. Yeah, so yeah, we so that's why we do it. We use those drugs so that we can get the blood to the lungs so it can pick up that oxygen, right? And so if you look down here at the bottom, it just kind of shows that's what we talked about, right? Superior vena cava, inferior vena cava to the right atrium, through the tricuspid valve, because we try before we buy, right? Tricuspid valve to the right ventricle, down to the pulmonary artery, then to the lungs, then back. See, then they're missing the actual valves. Those are important, right? Those pulmonic valve, aortic valve, those are important, right? So when it leaves the right ventricle, it goes through the pulmonary valve and then the pulmonary artery, right? Then to the lungs, right? And after the lungs, it comes back into the left atrium, goes through the mitral or bicuspid. Those are the same thing. Mitral, bicuspid are the same thing. Might be used interchangeably on the test, right? Into the left ventricle, and then through the aortic valve into the aorta, right? And then to the rest of the body. Okay. That is the blood flow through the heart and its primary structures and chambers. Very important that you go back and look at those things to familiarize yourself, because you don't use it a lot. We don't talk about all of that much, right? But you'll see that these things are vital in being able to not only pass the test, but treat your patient, right? Know what's going on with your patient. Know quickly how to lock down what issue the patient may be suffering from.
I'm sorry. I just want to say it again. Does oxygen pulmonary vasodilate as well?
Oxygen. Well, we can give oxygen, but I don't think oxygen in itself will be a pulmonary a dilator. I haven't heard that, because we can give somebody 100% oxygen. If they have pulmonary hypertension, it's going to be null and void, right? That pulmonary artery is just so tight, it needs something special to dilate, and that's when we were going to the nitrics, right? That nitric oxide will open that pulmonary valve up, or that pulmonary artery up. Sildenafil, which is Viagra, it will open up that pulmonary artery. Epoprostenol, which is Flolan, that will open up that pulmonary artery. But oxygen just by itself would not be enough, because if that was the case, we could just give people 100% FiO2 and solve that problem, right? But that's the reason why we go to these other steps, because we giving them 100% oxygen, he's still not oxygenating. Why is he not oxygenating? We giving him, he's on 5 a peak, 10 a peak, 15 a peak, 100%. What is going on, right? Then we realize when we drop a PAC line, we can, or Swan's Gans, we can put that line in and tell what the pressure is in the pulmonary artery. But before that, with that information that you've learned, you can kind of deduct that he might have pulmonary hypertension, right? His pulmonary artery might be so tight that the oxygenated blood can't get to the lungs, right? To pick up that good FiO2 that you providing in the lungs, but if the blood can't get there to pick it up, it's a shunt. Okay. And so that is where we are with that. Okay. But good question. All right. So then after you have the blood level of flow, you also have an electrical flow through the heart, right? So make sure you brush up on your terms and structures of electrical conduction, right? The electrical conduction is just as important as the blood conduction or the blood flow, right? They both have to be working on all cylinders or we're going to have a problem, all right? So the electrical conduction sends electrical signals to the heart muscle to stimulate the contraction, right? AKA depolarization, all right? So write that down. Contraction, aka depolarization, aka squeeze, aka systole. All right, all that's the same. Contraction, aka depolarization, aka squeeze, and aka systole. All those are interchangeable, right? Because systole is the top number of the blood pressure, and that is the pressure in which the heart contracts, right? And so depolarization happens when you have an influx of sodium ions into a potassium-rich cell, right? And causes a depolarization or squeeze, right? Or contraction. All those are the same. So when you go back and look at this, make sure you write that down because, like I said, the test likes to use a lot of interchangeable words, right? And if you're not careful, if you're not sure what that means, then you won't pick it, right? And it will throw you off on the whole question. Okay. All right. Let me take a look. Make sure nobody's trying to get in. All right. So I wish it would give me a little sound when I was trying to do that. All right. So continuing on. How do I get that to go back down? Hold on 1 second. All right, sharing my screen again. Here we go. All right. Can everybody see the screen that says electrical conduction system? Can still see it?
Yes, sir.
Okay,
Yes.
cool. All right, so here we are. Like I said, we just spoke about the blood flow through and all those structures, and now we're going to get into the electrical conduction system. Very important. Electricity is conducted from the SA node to the AV node, right? Through the bundle of His to the right and left bundle branches, and then ultimately the Purkinje fibers, right? So when we're looking right here on the screen, right, that electrical signal starts at the SA node, right? SA node. And then electrical pulse fires from the SA node down to the AV node, right? And then the bundle of His, and then that branches off into the left and right bundle branches, right? And then to these little Purkinje fibers that you really can't see here, but there's some little fibers that kind of excite the heart, the myocardium, right? That muscle. When you think about Purkinje fibers, you can think about if I plug, say you had a radio or something plugged into the wall, and then the other end is into the radio. If you snatch that out the radio, it's going to have those little frayed wires, the little frayed copper pieces. That would be your Purkinje fibers, right? Think of that. And if it touches something, it's going to contract it, right? It's going to shock it. And so that is how that situation. It's like a long plug, and it's a plug that's been pulled out of some machine, and now you are exposing the copper wires on it. Those will be your Purkinje fibers. But it's very important because you may have a test question that talks about the SA. Now, what is the pacemaker of the heart? What is the backup pacemaker, right? The pacemaker of the heart is the SA node, right? It's firing at a certain rate, I think 60 to 100, right? But then you have your AV node. If the SA node is not working, then the AV node tries to take up the space for that. You take up the work for that, but it's only hitting like at 40 to 60, right? So you're going to be bradycardia if you're only using your AV node. And that's why we have to have pacemakers put in, because that SA node is not firing like it should be, okay? But that is your electrical conduction through the heart, right? So we talked about the blood, We talked about the chambers, right? All of the chambers, the valves, and the structures. And then we talked about the electrical conduction system, right? Make sure you wrote down those AKAs. And so on your AKA sheet that you're writing down, remember we said contraction, AKA depolarization, AKA squeeze, AKA systole. Okay. Now, when the heart relaxes, you have a few other terms, right? We have repolarization, right? Repolarization, aka relax, right? Aka diastole, right? Your systole is your contraction, your diastole is your relaxation or your repolarization. What is the pressure in the system on systole, and then what is the pressure on relaxation, right? Or diastole? That's your blood pressure. Okay, that's how you find your blood pressure. That's what it's measuring. Okay, and so when you use those terms, I can't believe all this traffic today, sirens and everything on the day that I'm doing this. It's wild. But anyway, those are the AKAs. Make sure you write them down because you might have something that says pressure in the patient doing diastole or doing repolarization. You got to know what system, what step we are at when we do that. Okay. What are we talking about? We're talking about the squeeze. We're talking about when the heart is supposed to be relaxed, right? We're talking about left side, right side, right? All those things can make you go down a rabbit hole if you're not careful. Okay. So that is a couple of, and sometimes I'll tell you, hey, take these notes when it hits me to remember to tell you that because I remember seeing a lot of interchangeable words on exams. And they'll try to trip you up as much as they can. Okay. But that is the electrical conduction of the heart. Now, this kind of just has here some more information about it. The SA node, which is our sinoatrial, right? It's the heart's internal pacemaker, like we said, right? It causes the heart to beat. The SA node impulses can cause the P wave on the EKG. So the P wave is your SA node making that beat, right? The impulse from the SA node then travels to the AV, which is the atrioventricular node, right? The AV node conducts electricity between the atria and the ventricles. And then you have the bundle of His. The bundle of His is named after Wilhelm His, which probably won't be a test question, but the bundle of His is simply a bundle of cardiac nerve muscle fibers that conducts electricity from the AV node to the right and left bundle branches, right? And then those right and left bundle branches conduct electrical pulses to the Purkinje fibers. I like that word. And a bundle branch block results when electricity can no longer be conducted. So when people have bundle branch blocks like a second degree block or type 1 or type 2, a third degree block or a first degree block, that all is happening because of these right and left bundle branches are not conducting or firing like they should. Okay, and we can see that on an ECG or EKG. Okay, let's go on to the next one. Here it is again. SA node, AV node, bundle of His, right? Left and right bundle branches. And don't forget, guys, I know, don't forget when you're looking at something, it's the patient's left and right, not your left and right. This is the left and this is the right. Okay. A lot of people get that, forget about that and then it'll throw you completely off. All right. What about the cardiac cycle? Let's get into the cardiac cycle a little bit. This is the normal EKG rhythm here. Okay. EKG rhythms, they can be a bugaboo if you don't like it, right? And then being an RT, if you work in ICU or the ER, you need to know. You need to know the basics at least. If you are just giving treatments for the rest of your life, you probably won't see them as much, right? For instance, if you're in a nursing home or home care, something like that, you may not see it as much, but in the hospital and in NBRC hospital, you need to know. All right, so let's look at it. P wave is the first wave. Let me just read it right quick. The P wave represents the beginning of atrial contraction, or what did I say? Depolarization. There it is. Contraction, aka depolarization, right? The QRS complex represents the ventricular contraction or depolarization or systole or squeeze, right? All those the same. The Q wave is not always present in normal EKGs. Patients with myocardial infarction may have pronounced Q waves, okay? And then finally, the T wave represents ventricular relaxation, aka what? Repolarization, aka diastole, aka relax, okay? Now let's look at them. It's important to know kind of the relationship of them, because you're going to have some space in between that is for us to kind of understand what's going on cardiac wise with our patients. This is my P wave, this is my QRS, and this is my T wave, okay? But within those, we have a P, from my P wave to my R is my PR interval, or my PR interval from my P to my R, right? To where my QRS starts. That's my PR interval. And we have to measure that when we're looking at blocks, because your PR interval will change with your second degree blocks, okay? Well, at least for type 1, it'll change. Type 2, it just doesn't change, but something else is happening. We'll talk about that when we get to that, right? Then you have your QRS complex, of course, and then your ST segment, right? From my S to where my T starts is my ST segment, right? And then all of this from my Q to my T is my QT interval. Now that is kind of where nursing looks at a lot of patients, because they have to decide whether they can take certain psychological medicines and other medicines. I'm not sure 100% of what other medicines, but there are some medicines that they have to look at that QT interval to see if it's going to be affected by the medication that they give, right? Not nothing that necessarily respiratory would have to deal with, but just knowing that is good to know, okay? But this is your basic EKG pattern right here. PQRST. All right. Now, it kind of talks about some of these intervals. Hold on one second. I think I'm still sharing you. Okay. All right. My PR interval, as we talked earlier, PR interval starts with the beginning of the P wave and ends at the beginning of the QRS complex. The normal PR interval is about 0.12 to 0.20 seconds, right? PR interval may be prolonged in first and second degree heart blocks, okay? ST segment. ST segment begins at the end of the S wave and ends where the T wave begins. Changes in your ST segment may indicate ischemia or infarction of the heart muscle. Ischemia just means death, right? Death of the heart muscle or whatever area that's affected, right? Or infarction, which is a heart attack of the heart muscle. Okay? All right. Let's go on to the next section. All right. ST depression. Now, sometimes you'll have ST depression where your ST segment is really low, or you may have ST elevation, right? And there are some physiology behind those things. If you have those issues that what you know on the test, then you need to know what answer to choose. What might be the problem with these different ones, right? So ST depression may indicate ischemia or no blood flow to the heart, right? And then ST elevation may indicate myocardial infarction, which is a heart attack, right? And so we can look at that on our ST segment. I can't believe it. All right. Let's look at this EKG again, and let's look at these segments. This is the ST segment right here. Sometimes if this is elevated really high, like the T part, if it's really up high, then that will indicate MI, right? We can look at that. We can look at an EKG and say that he's got a STEMI or some kind of heart attack has happened either in the past or happening right now, right? You can't really tell what a ST elevation, whether it's old or it's new, but we know that it has happened at some time before, right? So who can tell me if a patient comes in and like you have a test question, patient comes in with chest pain, and then you get an EKG, right? And then you see a little bit of ST elevation, but you're not sure if it's now, right, happening right now, or did it happen sometime in the past? What is another test we can do to determine whether something is happening right now?
Echo.
Yes, maybe that, but what's something quicker we can do? Some kind of lab we can draw to tell us if we're having person is having an MI right now.
Like troponin levels?
Troponins. So you'll get a troponin level. So when you're doing simulations, that might be something you want to get, right? It may ask you, do you want to get a CBC? Do you want to get an echo? Do you want to get a troponin, right? And you only can choose one, choose the troponin. Yeah, you might get an echo at some point, but right now, in an emergent situation, you want to go ahead and get a troponin level, right? So picking the best choice is where a lot of people miss some of the questions because they pick a good choice, but it might not be the best choice at that moment, right? So good, a troponin level. But then they always follow up. Remember that they got to follow up 3 hours later because sometimes if you just had a heart attack and walk right into the ER, your troponin level might not be up. It takes about 3 to 4 hours for that hormone to be shown in the blood after a heart attack or some kind of heart injury. Okay, so they'll get one on you and they'll make you wait for about 3 or 4 hours and get another one. And if you still is low, then you're not having a heart attack, right? So that's important to know because you may have to choose from some of those things when you're getting answering questions on your simulations. Okay, let me check, make sure nobody's coming in. Okay, good. All right. All right, let's go on to the next one. All right. Last one on this one. So we talked about ST, depression, and all that. Okay, axis. Not going to see a whole lot of questions on axis, but they do throw it in here because you just never know. But the axis is the direction electricity flows through the heart. That's known as the axis. The normal axis, which is direction of electricity, travels from the SA node down towards the left ventricle, right? Why is that important? Well, an axis deviation may suggest the presence of heart or lung disease, right? So like a left axis deviation may indicate left ventricle hypertrophy, a left bundle branch block, or may simply occur during exhalation, right? A right axis deviation may indicate right ventricle hypertrophy, right bundle branch block, COPD, or may occur during inhalation, right? So those things are, it's kind of important because if we are respiratory therapists, we're really looking at whether this patient is suffering from CHF issues or maybe they're suffering from cor pulmonale, right? Knowing the basis of that gives us the tools to take the right direction in our process making, decision making, information gathering, right? All those things are on the simulation test. So, they have a list of things they want you to ask you, do you want to gather, right? And if the question tells you there's some right axis deviation noted in the EKG. Now my mind's thinking right side problems, right? I'm looking for JVD. Are they sweating profusely, right? Or they have orthopnea? All those things start making my mind race and lead me to a certain diagnosis. Okay, so that's why they're hit so hard on these, because it's important, especially in the decision making skills. Okay, normal deviation or direction of electricity should be about negative 30 to 90 degrees, as pictured below. So this is our normal axis, right, of how it goes, right? Should go down kind of like that. All right. Now, with that information, let's take a quick exam. Well, no, I'm sorry. This talks about the cardiac exam. I'm sorry. The cardiac exam. How can I, when I get a patient, I'm not sure what's going on. These are some symptoms that you can look at. The question may give you some of these symptoms, right? And help you decide, yeah, this is what's happening. Or yeah, he's just orthopnic. Or yeah, he or she is having an MI. Or this is a COPD, or, all these kind of things. And teamed up with what we already talked about with the physical exam, right? Chest inspection, right? Auscultation, the things we just talked about the last Saturday we were here. You have to put all that together when you're trying to decide what's going on with your patient, right? So orthopnea. Orthopnea is simply shortness of breath while you're laying down. Somebody who can't lay flat usually has, it's common with people with CHF. If I'm laying flat and I just can't, they say, oh, I can't, don't lay me back flat. Then that person suffers from orthopnea, right? That is a common for somebody who has CHF. Remember, CHF is a left side heart problem. What about JVD? Jugular venous distension. JVD occurs when blood flows backwards from the right atrium into the jugular veins, right? JVD is often a sign of fluid overload and or heart failure. So remember, here we are right here. This is our right atrium, right here, right? So if we have a patient who's has JVD, what's happening is as the blood comes back to the right side of the heart via the superior or inferior vena cava, right? It gets to the right atrium, but can't get down into the right ventricle. It might be a tricuspid valve problem. It could be, the cor pulmonale, whatever it is. Now blood starts backing up, right? Backing up through that superior vena cava and that inferior vena cava. And you can see it pulsating in their jugular vein, right? It's not the artery, it's the jugular vein that is distended. And that's because of the backwards flow from the right atrium to the jugular vein in JVD. Okay, that's a right side heart problem. What about edema? Edema appears as swelling, right, due to abnormal accumulation of excess fluid. Edema is associated with fluid overload, which is also congestive heart failure. Renal failure, right? Somebody who has kidney problems, if they can't excrete the waste or excrete the fluid, it's going to start backing up into the heart, right, into the lungs. Ultimately, it's going to show up in that area, right? That's why you have to get that fluid off. They have to get dialysis. They have to get diuretics and all kind of things like that to help in acute CKD, right, acute kidney disease. Other treatment for edema, of course, we talked about, which is diuretics like Lasix and or positive inotropic agents like digoxin. Digoxin is a positive inotropic agent, which causes the stroke to be harder, right? That depolarization, that AKA squeeze, that AKA systole, all is stronger when the patient is taking positive inotropic agents, okay, which is digoxin. Keep that in mind because they use that word. I've seen that several times on the sample test, right? They talk about digoxin several times. Diaphoresis, that's when somebody's simply sweating real profusely, right? You see that in people with heart failure. Capillary refill time, right? Remember, we learned that in school when we first got to respiratory school. That was one of the first things we did in patient assessment. But remember that, right? It'll show its head back up on your test and be like, I haven't seen or even dealt with capillary refill time in almost months or years, right? But that is the time it takes for color to return to normal when the nib bed is blanched. So when I squeeze my nib bed, I squeeze it down real hard with my other fingernail for about 10, 15 seconds, and it's going to turn white. Then when I let go, however long it takes for that to get back red is my capillary refill time, right? So just remember, poor capillary refill is associated with poor cardiac output, poor perfusion to the extremities, okay? Conditions like shock, dehydration, peripheral vascular disease, right, are all associated with poor capillary refill time, all right? And then finally, skin temperature. Somebody's skin is cold, clammy, sticky, right? That may be another sign of heart failure and shock. So the reason why you're seeing this, guys, is because when you have a simulation question, it may tell you patient had skin was, if they ask you, do you want to know what their sensorium is? Do you want to know what their skin turgor is, right? Do you want to know what their capillary refill time? You want to say yes when you're suspecting cardiac issues, because that can say, yes, it truly is something cardiac, or no, it's not, right? Could be simply dehydration. Just give him some fluids and he go back out of there, right? Especially people who may have drunk a lot of alcohol. You can become very dehydrated and have these issues, and it could be simply something like that, okay? But you need to know how to find the root of the problem, okay? Second page, what about paradoxal pulse or pulseless paradoxus? Pulseless paradoxus, you might see that. The question may say patient has pulseless paradoxus. Well, if you haven't seen that or heard that in a while, you have no idea what choices to make. And every point counts, right? So a paradoxal pulse occurs when the systolic blood pressure drops severely during inhalation. So say my systole or my depolarization or my squeeze pressure, right, normally is about 130, right? But when I breathe in, it drops down to 80 or 90, right? That's a severe drop in my systolic number, right? That's a grave sign. And causes include cardiac tamponade and severe COPD. So every time you take a breath, your heart blood pressure drops. You got to breathe, right? So that's scary. That's scary. Who can tell me what cardiac tamponade is? Who can tell me what that is? I can't believe all this traffic today. Anybody can tell me what cardiac tamponade is? Okay. Y'all still can see my screen, right?
Yes.
Okay. Cardiac tamponade. Because they may tell you patient has cardiac tamponade, right? If you don't know what that is, now you know. This is the heart, right? We already know the heart has 3 layers, right? We have the endocardium, exocardium, and the myocardium, right? The outer, the inner, and the muscular layer. Now, it also sits in a sac, kind of like cellophane, right? You know how you buy something like a pack of gum, and has that little cellophane on it that you have to tear that little clear plastic off to get to the gum. Well, the heart sits in a pericardial sac, right? And when blood gets into that pericardial sac, then you have a cardiac tamponade, okay? Now, you guys might have to refresh me. I know the endocardium, myocardium. I don't know if the out one is the pericardium or is it I don't think it's exocardium. I think it's pericardium. So, don't quote me on that, but I believe it's pericardium. But there's 3 layers, but the hearts, all 3 layers sit in a sac. And that sac, when blood gets in there, then it becomes cardiac tamponade. And remember, you don't have a lot of space. So if the heart has a sac that's filling with blood, now the heart is being compressed, okay? Because the sac does not stretch. So if blood is getting there, it's starting to compress on your heart. So that can be painful, and that can cause be a grave sign for cardiac issues. So remember that, okay? Hypertrophy, heart disease like hypertension, valve stenosis, and CHF often lead to enlargement of the heart muscle. Anytime you work a muscle out, it's gonna get what? Bigger. Okay. So if my left side is working harder all the time, then it's going to start to get bigger. And that's when sometimes we start to see that left ventricle become much bigger, right? It starts to get much bigger than it should be. You can see that on the x-ray, right? The diameter across the chest is the heart's diameter is huge. That's hypertrophy. That means something's going wrong, right? Somebody has CHF and the heart is trying its best to pump and is doing it harder and harder, so much so that the muscle itself is getting bigger and bigger. That's not a good thing, okay? Normal heart sound. You know, you got your lub dub, right? Your S1 and your S2 are the normal heart sounds. But sometimes these sounds are described as the lub dub. The lub corresponds to the S1 and the dub is the S2. But what about our abnormal heart sounds, right? Extra little sounds you hear between the lub and the dub, right? You shouldn't be hearing anything else, right? And S3 and S4 are abnormal heart sounds that may indicate cardiac anomalies or heart failure, right? Now remember, S3 is a normal heart sound in many children. And speaking of children, on our next class, next Saturday, we're going to go into some pediatrics, okay? So be prepared for that because a lot of people have problems with pediatrics, okay? Especially if you already have graduated and you work with adults. Pediatrics is out of sight, out of mind, and you lose that real easily, okay? So we will go into some pediatrics on next Saturday, all right? Murmurs. Murmurs are abnormal heart sounds of turbulent blood flow as it passes through the heart. Murmurs may occur during systole or diastole. So it may happen during depolarization or repolarization. It may happen during contraction or relaxation, right? So I keep saying it because I want you to be able to synonymize these words together. They mean the same thing, but you may see them several different ways. I don't want you to get tricked, all right? Bruits. A bruit is the sound of turbulent blood as it passes through the carotid artery. So these are my carotid arteries, right? So the doctor may put the stethoscope up here and listen. Well, that's what he or she is listening for. If they hear noise, then that's a bruit, okay? And a bruit is when it's turbulent blood. Turbulent is not smooth. So there might be some plaque or something in your arteries that's causing this blood to tumble around, right? Something's wrong. But that's just a way we can examine our heart, okay? And then the P2 is the sound a pulmonary valve makes when it closes. A loud P2 may indicate pulmonary hypertension. Because remember, when we're trying to see if somebody has pulmonary hypertension, the telltale way is putting the Schwann's Gans in, right? We got to put a PAC line in, right? That's evasive. That's very invasive. So if I can listen, and if I have a cardiac stethoscope or a cardiologist who's really keen to listening to these different sounds, we want to use them as much as possible to say, hey, that P2 sound is really, really strong, right? Not only are they desatting, but they could be desatting for many other things. Doesn't have to be pulmonary hypertension. But one way to see, is it pulmonary hypertension without being so invasive, would be the P2 sound, okay? So if that P2 sound is loud, now that gives me the reason and gives me motivation to go ahead and talk about a PAC line. So then we can know for sure, right? But you don't just start going around throwing PAC lines in everybody, you know, willy-nilly, because that's a source of infection. Anything that's going in and out of the heart comes with risk. So, you know, you want to be safe. Make your patient safety is always key, okay? Always key. So exam tip, it says recommend an EKG for patients with abnormal heart sounds. So now you know, if you have a test that says, do you want to get an EKG, right? It says, yes, recommend an EKG and an ECG for patients with abnormal heart sounds. So if it tells you patient has a loud P2 or has some bruits, has murmurs, recommend an EKG. Don't leave that out, okay? Choose that. They're telling you now. That's an exam tip. Make sure you write that down. And here's a picture of the heart, like I just showed you with my model. All right, let's see where we are. All right, so we'll end that part with we'll come up on this cardiac pathophysiology. These some of the not drugs, but the diseases, right? The diseases that we see. CHF, and I won't go through them, long, guys. I just want you to make sure you get a good foundation in these things to help jar your memory on these things so that when we're done with our syllabus, right, we can all go take the test right then while it's fresh, okay? CHF, any condition that weakens or damages the heart can cause CHF, right? You don't have to be overweight to cause CHF, any condition, right? Treatment options include oxygen. For whoever asked me about oxygen earlier, this is when you would help with oxygen. Somebody who has CHF, you want to treat with oxygen, diuretics. Here it is again, positive inotropes, right? And remember, what is the drug I said is inotrope? The positive inotropic agent. What's the name of it?
Digoxin.
Digoxin. You see that? It's probably, you probably need to choose it, okay? Anytime you're having a depolarization, aka squeeze, aka systole issue, you probably need to give a positive inotropic agent. And the one we use right now, the gold standard, is digoxin. Okay, that'll help push that stuff on through there and clear your heart out as much as possible, right? Then, of course, we can do CPAP, right? CPAP, or positive pressure, also helps with CHF because once we get the fluid, once those pulmonary veins, once they start coming, the fluid and blood starts backing up right here because the left side of the heart can't pump it. We're giving digoxin, but it's still not enough, right? What we can do is give CPAP, and CPAP will push this fluid into the interstitial space, and that's where your Lasix can pick it up. So your Lasix can't get into the atrium, right? It can't really affect a lot of places. The fluid has to be pushed into the interstitial space of the heart and, all those structures. Once it gets there, that's where the furosemide or the Lasix can actually get it and get it out of there, okay? But you can give Lasix all day long. If the fluid is not in the interstitial space, then it can't pick it up, right? It's not going to work. So positive pressure like CPAP will help push that fluid into the interstitial space so that your medicines can pick it up, okay? Diuretics, positive inotropes, again, digoxin or digitalis. Now, digitalis is the another trade name, right? And those help the heart contract with more force. CPAP often helps open the flooded alveoli, right, and move it back into the vascular. That's what I just said. If there is fluid in the alveoli, furosemide or Lasix cannot work. It cannot get into the alveoli to do anything. Only thing can get in the alveoli is gases, right? Other than that, furosemide can't get in, right? And so since it can't get in, we got to figure out a way to get the fluid out of the alveoli so that it can be picked up in the vasculature, right? When it gets back into the vasculature, which is the interstitial space, that's where the medicine can work, okay? But until then, it's not going to work. So that's why you use CPAP. So anybody who has a CHF comes to the ED with known CHF, short of breath, diaphoretic, right? NIPPV may be your choice, right? Before we just tube them, let's try NIPPV. If somebody having short of breath, he's He's struggling using accessory muscle use, right? We already said we have, what did we say, the kind of breath sound you hear with CHF? I told you to make sure you remember.
Crackles.
Fine crackles, good. Not coarse crackles, fine crackles. So he came in with fine crackles. He's short of breath. He's diaphoretic, right? He's using accessory muscles, and he told you he has CHF. Put the man on a BiPAP. Give him some Lasix and some positive inotropic agents, and you'll fix him, okay? Now, what are some of the signs and symptoms? Labored respiration, accessory muscle use, fine crackles to auscultation, diaphoresis. Now, what about the x-ray? This is important because when you see, they may give you an x-ray and then ask you what's wrong with this patient. Fluffy infiltrates and or curly lines, rather curly B lines on an x-ray is CHF. Don't forget that. They may give you nothing. They may say he's short of breath, he's got diaphoretic. We got an x-ray on him and show fluffy infiltrates in bilaterally and curly B lines on chest x-ray. Bam, we already know that's CHF, okay? So highlight that in your notes. That's CHF, telltale sign, curly lines, those curly B lines. I don't know if they still call them curly B lines. I might have to ask Charles if they still do that. I'm not sure. I know it's curly lines, but it used to be curly B lines. Not sure. But if you see curly, you know it's CHF, okay? Pink froth secretions due to pulmonary edema, right? Pitting pedal edema, that's around the ankles. You can push the skin of the ankles and it leaves a big print. That's pitting edema, I'm sorry. Orthopnea and an elevated BNP. Okay, those are some of the signs and symptoms of CHF. So when you get it's getting cold out here. When you get when you're doing a simulation, right? And it talks about some of the symptoms this patient has, this is what's going to help you remember what disease process are they describing, okay? It's kind of like having your eyes, having a blinder on. Being a good respiratory therapist, you should be able to put a blindfold on you and somebody just describe all of the symptoms the patient has, and you can go right to what it is without looking at them for yourself, okay? You will all get there. So what are some of the diagnostic tests? We can do a chest x-ray, right? Which is curly B lines or curly lines, butterfly or bat wing pattern, fluffy infiltrates or opacities, right? All those things mean CHF or pulmonary edema, right? And which CHF is pulmonary edema because it's congested area around the heart, okay? A BNP or brain natriuretic peptide elevation, right? A BNP. Echo. Somebody else said something about echo earlier. That's right. An echo is a good test to use when we're trying to suggest or determine CHF, right? But just remember what other symptoms they give you. If you only have a choice of one thing to choose, do we put them on a BiPAP? Do we get an ABG? Or do we do an echo, right? It depends on the symptomatic of the patient. Is he symptomatic or does he just have a history of it, right? If he comes in and he got a history of CHF, right, and he was having a little pink secretions every now and then yeah, let's get an echo and see how bad it is, right? See if his heart is performing and beating at the strength it should be, right? But if it says he's sweating, he's short of breath, he's using accessory muscles, then the echo would not be the best choice. You see what I'm saying? The best choice needs to fix the hypoxic part, right? Fix the shortness of breath first. And that would be something like put them on a BiPAP. Let's do that first, get them stable, then we can get an echo, okay? So they do that. They say which one you want to do first, or what is the best choice to do right now, right? Then they may ask you some other ideas or some other information you want to gather. So be very careful when you're reading these tests, that every point counts, okay? And then how do we treat CHF? 100% oxygen, right? Even if they have COPD, if they're, be careful withholding oxygen because somebody got COPD, right? They used to show a little cartoon when I was in school, respiratory school, about a doctor who came in and saw a patient that was short, his sats were a little low, but he had COPD, so she wouldn't give him any oxygen. Then another therapist came in later, and the patient was laying in the bed blue, and she was saying, "Well, he got COPD, so we couldn't give him no oxygen, right?" So it was made as satire, but never withhold valuable oxygen. I don't care what they have. We can always give it for a short period of time, but the treatment for CHF is 100% FiO2. Give them some Lasix, morphine if needed, right? Because morphine not only does morphine help with pain, but morphine also helps with hypoxia. It helps you not know that you're hypoxic, right? CPAP, BiPAP, positive inotropic agents such as digoxin or digitalis, and then sometimes nitroglycerin. All right, so that's the left side. Those are things that are happening on the left side, right? Now, what about the right side? Which the right side is what you'll see the most, being a respiratory therapist, right? Somebody with CHF that's not on a vent or nothing like that, you might not even get called. It might not be an issue with you until it's a right side problem. When it's a right side problem, the respiratory therapist will have a little bit more dealings with that patient, right? Cor pulmonale is a abnormal enlargement or dilation of the right ventricle due to pulmonary hypertension, right? And COPD. Signs and symptoms are dyspnea, JVD, elevated CVP, PAP, and pulmonary capillary wedge pressures, right? CVP is your central venous pressure. PAP is your pulmonary artery pressure, right? And your PCP is your pulmonary capillary wedge pressure. All these things are deoxygenated issues, which means it's on the right side, right? Your central venous pressure, your vein is deoxygenated. Pulmonary artery pressure, your pulmonary artery is deoxygenated. And your pulmonary capillary wedge, so your pulmonary capillaries are deoxygenated. So remember, blue is the right side. That's the deoxygenated side, blue, right? And your red side is your oxygenated side or your systemic side, right? Test, like somebody said earlier, echo, right? Cor pulmonale, we can do an echo for them as well. How do we treat them? Cor pulmonare, oxygen, right? And then consider digoxin and diuretics and nitric oxide, right? And now you're also going to see Flolan or epoprostenol is what it's called. Velitri is also a trade name for epoprostenol. So you'll see some of these things, a lot of other things coming up now. Like I said, Viagra. Sometimes they'll give Viagra before they give nitrics just to see if there's a change, right? Male and female. If a female is suspected to have pulmonary hypertension, they may give her some sildenafil or sildenafil, I think it's sildenafil, which is Viagra, right? And let's just see, does her oxygen go up? If it does, now we know she has pulmonary hypertension, and we can focus more on that problem, right? All right. What about an MI? The third thing, myocardial infarction, right? Now, remember, a myocardial infarction is simply when there is death of the heart tissue, right? And the reason why the tissue could die is because life-giving blood couldn't get there, okay? Now, why wouldn't it get there? Well, this plaque, right? If the coronary artery, which is this part here, remember we talked about the red coronary arteries. These are the red coronary artery, and then you have the coronary veins are the blue ones here, right? So just say, for instance, this branch of the coronary artery got blocked with plaque, right? Then anything distal to this gonna die. As simple as that. Okay? And when it dies, you know it, because it's gonna give you a heart attack. All right. So ways we can go in and bypass that, right? Put a new piece there to go around the buildup. We can go in and put a mesh splint in and open up, clean that plaque out, open up that coronary artery and restore blood flow. to that place that died, right? Those are things we can do, bypass or stent. But that's what's happening when you have an MI, okay? So it shows you here, you have blocked flow of blood because of this plaque. And what do you have down here? Dead muscle tissue, necrosis, right? Dead, AKA necrotic, okay? And it represents on the EKG as a elevated ST segment, okay? So those are ways we can go in and see, oh, okay, this is what's going on. I got an EKG. He has an elevated ST segment. Not sure if it's old or new. So we drew a troponin, right? But he said his chest is hurting. So yes, that troponin is high. And so we can take him to the cardiac cath lab, run some dye through there, and we can find this block. Once we find that blockage, now we can make a plan to either bypass it or put a stent in it. Okay? That's how that works. Number 3, an MI, which is what I just said, occurs when part of the heart muscle dies because of ischemia, which is lack of blood flow, death. Ischemia causes death, which is necrosis, just like in your brain when you have a stroke. If you have a clot, a blood clot in one of your capillaries or one of your vessels in your brain, right? That's ischemia, a blockage, lack of blood flow. That's ischemia. And ischemia leads to death of the tissue or the brain tissue. And that's when you can't, move one arm or the other or speak or whatever it is. Whatever part of the brain that functions or whatever function that part of the brain has no longer exists when blood can't get there. And if ischemia, which is the lack of the blood flow, right, will lead to death or necrosis. Okay? That's how it works. Okay? So you have STEMI, which stands for ST elevated myocardial infarctions, and you also have a non-STEMI, right? That the non-STEMI is for non-ST elevated myocardial infarction. So some people can have a heart attack, but the ST elevation does not increase. That's called a non-STEMI. So you can be tricked on that, right? So don't think just because it doesn't look like a STEMI or doesn't look like a heart attack on the EKG does not mean it is not a heart attack. Okay? Those are just tools we use. All right, some of the signs and symptoms: chest or jaw pain, nausea, vomiting, diaphoresis, ST elevation, or pronounced Q waves. Those are some of the signs and symptoms of myocardial infarction, MI, heart attack, right? Some of the other diagnostic tests: 12-lead EKG, right? Continuous blood pressure monitoring, cardiac enzymes, troponins. A normal troponin, write this down. Normal troponin should be less than 0.1. Normal troponin should be less than 0.1 because you may get a question that says he has a troponin of 0.3. You say, oh, 0.3, that ain't nothing, right? No, that's very much something. That's a heart attack, okay? Troponin should be less than 0.1, so it should be 0.004 or something like that. That's what you want, right? That means there's no sign. But don't forget, once you get one, you got to get one 3 or 4 hours later. And Charles, are you still on here, Charles? Okay, I do that because Charles works in our ER, and I asked him to be on here with us as well. But I think it's 3 hours, but it might be 4 hours. But I'll check on that. All right, the treatment is 100% oxygen, aspirin, amiodarone, and nitrates. And aspirin is because we want to thin that blood out a little bit, because it might be a blood clot that has caused that ischemia, right? Which led to the necrosis, right? Which leads to the MI, right? It's a domino effect. So if we give a little aspirin, we can thin that blood a little bit and maybe help go around the blockage and help blood get back to that, because you don't have much time, right? Don't have much time. And what about a PE? Pulmonary embolism. That's scary. We see a lot of patients that fall right out in your face over pulmonary embolism. You thought it was a heart attack. You start treating for heart attack, and it wasn't a heart attack. It was a PE, okay? But it looks just like a heart attack. An embolus, which is a blood clot, right, blocks the pulmonary vascular, causing dead space ventilation. Dead space ventilation occurs when there is ventilation, but no perfusion, right? Ventilation, but no perfusion. But if you have perfusion and no ventilation, that's shunt, right? And so when you think about the heart, if the blood returns from the superior and inferior vena cava, but can't get through the pulmonary artery, then that means no ventilation. The blood is returning to the left side without ventilation, in a sense, okay? If it didn't pick up oxygen, then it didn't ventilate, all right? So that's what you have to use in your mind. Perfusion with no ventilation is a shunt. Ventilation with no perfusion is dead space, okay? Make sure you know the difference between the two because they can get tricky, all right? They can get tricky. But I love dealing with those, so we can have some sidebars with those going forward. Anytime you need me, guys, you just text me or call me and say, hey, I'm having a problem with this. We're working on this, and whatever I can do, I'm here for you, okay? All right, let's go on. Diagnostic tests for PEs, right? They're a little bit different. We have to do a ventilation perfusion scan to see if we have a lot of ventilation and no perfusion, or do we have a lot of perfusion but no ventilation, right? A spiral CT scan, ABGs, right? Some of these things can help determine pulmonary embolism, okay? Pulmonary embolism, which, what do you think going to be low in an ABG for pulmonary embolism? Remember, we said pulmonary embolism causes ventilation but no perfusion, right? So what value are we looking for in the ABG that will kind of help us determine whether this patient might be suffering from a PE?
The PaO2?
Yeah, we can look at PaO2, especially for shunt issues, right? Because if the PaO2 is really, really low, I mean, it's not picking up any oxygen, right? Also, ventilation. So write this down too, guys. I want you to write this down. It's another AKA. CO2, AKA acid, AKA ventilation, AKA carbia, AKA capnia. And then finally, AKA respiratory. Okay? And I probably won't be able to remember them all again, but CO2, AKA ventilation, AKA acid, AKA carbia, AKA capnia, and AKA respiratory. It's all the same, right? It's all meaning the same thing. Okay? So if CO2 is causing a problem, then it's a respiratory problem because CO2 is respiratory, right? If CO2 is a problem, it's a ventilation issue because CO2 is ventilation, right? If it's a CO2 problem, it's an acidic problem because CO2 is an acid, okay? So if you keep those kind of things in your mind, you can kind of gauge what to look for with certain situations, okay? So how do we treat a PE? We treat a PE with 100% oxygen, right? 100% oxygen. Because you got the ventilation, it's no perfusion, right? So we're going to give as much oxygen as we can give to help that little bitty perfusion make a difference, right? Pharmacology or pharmacotherapy. We give anticoagulants, so blood thinners, right? Heparin, warfarin, help delete that clot, right? Pain relievers, because a PE can cause pain. That's when people grab their chest and fall over because that blood clot has caused pain, right? Again, here goes your special drug, digoxin, right? Because if there's there's ventilation, but there's no perfusion, so let's help that perfusion by giving more oxygen, making the heart pump harder, right? Anything we can do to help that perfusion. Even, and I don't see it on here, but even hyperbaric, right? Hyperbaric chambers also help with perfusion, right? I'm surprised they don't use it for that. Thrombolytics such as streptokinase, urokinase, or TPA, right? Those are some of the things we also kind of bust up that clot. And then finally, surgery or the Greenfield filter, which I have not heard of until today. I don't know what that is, but now you know. You may see that on the test, the Greenfield filter. So if they say you want to, these are some options we can use to treat this PE. Would you want to use thrombolytics? You want to say yes. What about anticoagulation therapy? Yes. Do we want to give 100% oxygen? Yes. What about the Greenfield filter? And you're like, no, right? But you should say yes, right? That is evidently a treatment that is used for PE. Now I'll look into that and see if I can give you more information on that later. But I'm not sure what that even is. I've never heard of it before. All right, let me check, make sure nobody's trying to get in. Nope, nobody's trying to get in. All right, great. Okay. Almost done, guys. You're doing great. About 30 minutes left. What about some congenital heart defects? You got some congenital issue when you're born with, right? You have the patient forming ovale, right? Corcation of the aorta. You have tragility, or I always have a problem with that word, tetralogy of Fallot, and then patient ductus arteriosus. Usually, that's stuff like transposition of the great vessels, right? Things are swapped out. You have on this first one, you have the foramen ovale fails to close, right? That's an issue. Over here, you have for the correction of the aorta, you have a narrow segment of the aorta, right? Look at that little, it's like it's pinched off, right? And so you got good blood flow, but when the blood comes through the aortic valve into the aorta, it has to go through a real small passage right there, which will cause great pressure in that area based on the Bernoulli principle, right? You're going to have great pressure because it's so narrow, and that can cause issues because the blood can't get to the body. So you're probably going to have some low blood volumes because of that, right? And then patent ductus arteriosus, he says the ductus arteriosus remains open, right? So it always remains open. And then the tragedy of Fallot or Fallot, people say it different ways. The aorta emerges from both ventricles, right? You have intraventricular septal defect. Look at that. Blood is mixing because there's a defect there or a hole. You have stenosed pulmonary semilunar valve. So your pulmonary artery, not your pulmonary artery, but your pulmonary valve is stenosed, which means tight. Like you got your finger over a water hose, right? If you put your thumb over a water hose and just remove your thumb just a little bit, you're going to have skeet, 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 right? High pressure, high resistance, right? Based off Bernoulli principle. And then, of course, you're going to have an enlarged right ventricle because it's trying to push, right? Anything we say, hypertrophy of any muscle is because it's trying to push. So if the right side, usually the left ventricle is always bigger than the right because the left is the systemic side, which is a higher pressure. But if someone has tetralogy of Fallot, right, you have a lot of different things going on inside this heart. And if you have that problem, then you have this time your right, see that muscle, that the myocardium of the right ventricle is thinner than the myocardium of the left because this one should be bigger. It works harder. It's higher pressure. But in these patients, this side is bigger. See how much bigger it is? It shouldn't be that big. Look at the other pictures, how the myocardium of the right side is thin there, it's thin there, it's thin here, but over here it's thicker because the right side is pumping so hard trying to push fluid through this little bitty valve. That valve is too small, right? Too small. And not only that, but also blood is pushing over into the left side. So you have a defect in the septum, right? Which septum is just a layer of tissue that separates the right ventricle from the left ventricle. And if blood is getting over there before it goes to the heart, to the lungs, you got a problem, right? It's just that's really a bad situation. That's a really ill situation to be in, because now you have mixed blood, and it's deoxygenated blood in your left ventricle, which should not be happening. Those things that's causing shunts, right? It's causing shunts. So study up on those guys. Study up on your congenital heart defects. Go back and look at some of those, because they may tell you this patient has a history of it, right? And you kind of have to get up basics. There won't be many questions over that, but it gives you an idea of what you might be seeing, right? Oh, that's why his PaO2 is low, or that's why his pressures or his pulmonary artery capillary wedge pressure is so low or so high, right? Those things give you a avenue to go down as therapist. All right. What about the newborns? Congenital defects are structural defects of the newborn, right? Now, congenital heart defects include transposition of the great vessels. And that is a phenomenon that's amazing to me. And all that means is the pulmonary artery is where the aorta should be, right? And the aorta is where the pulmonary artery should be, right? So when blood is in the right ventricle, it goes to the pulmonary artery instead of the aorta, right? It should be, the patient that is if blood is in the right ventricle, it's supposed to go to the pulmonary artery, right? To go to the lungs. But the baby who has transposition of the great vessels, the blood that is in the right ventricle goes to the aorta. So it skips the lungs. And that is perfusion without ventilation. That's a shunt. Okay? You got blood flow, but there's no ventilation because it didn't go to the lungs to ventilate. It didn't go to the lungs to pick up the oxygen, which is the ventilation, right? The ventilation process. So when you have right ventricle going straight to the aorta, that's a problem, right? You can never oxygenate. That baby will never oxygenate unless we switch them back, okay? So that's important, and that's amazing to me that mistake can happen, okay? And then we talked about the corrugation of the aorta, trigology of Fallot, PDA is patent ductus arteriosus, ASD, VSD, and PFO. So kind of go back and look at those in your peds part, because that's some of the things we see with our newborns that has to be fixed immediately, okay? Signs and symptoms, look at this baby. Peripheral cyanosis. This is bluish discoloration of the digits and limbs due to circulatory insufficiency or failure, right? Peripheral cyanosis or acrocyanosis, we talked about that last class. Peripheral cyanosis is also known as acrocyanosis. Alone is not a sign of hypoxia. Don't forget that. Peripheral cyanosis or acrocyanosis does not necessarily mean they're hypoxic. That's blue hands, blue feet, right? So it may tell you, baby came in with blue hands and blue feet. You think automatically, oh, give them some oxygen. Let's put them on oxygen. No, that's not what it is. It's acrocyanosis is not a sign of hypoxemia. Therefore, by itself, it may not require oxygen, but it might be some other issues that are going on as well, but that's, to be determined, okay? Central cyanosis. Now, this is hypoxemia. It's a bluish discoloration of the lips and oral mucosa, and it is a sign of hypoxemia. Central cyanosis is a true cyanosis and needs to be treated with oxygen first. Another symptom is heart murmur, right? A heart murmur. How do we do tests to find these congenital defects? We can do an echo or a chest x-ray, okay? And then how do we treat congenital defects? With oxygen, mechanical ventilation, and surgery. When somebody has transposition of the great vessels, we have to go and switch them, okay? We got to switch them back and get them working right. All right. Where are we now? Let's see. All right, we have 20 minutes left. So the next section, guys, is EKGs. But since we only have 20 minutes left, I'm going to go ahead and end with a simulation. So let's go into a similar cardiac simulation. Adult cardiovascular simulation. All right, we're going to do, let's do Mrs. Johnson. All right. Does everybody see my screen still? It says Mrs. Johnson.
Yes.
You say yes?
Yes.
Okay, good. All right, so Mrs. Johnson, here we go. This is an example of a clean sim, all right? And it's a cardiac clean sim. It's going to ask you different things, and we have to find out whether the physician agrees or not. Now, if we fail this simulation, it won't be necessarily because we did the wrong thing, because I may, if you guys say, no, I don't want to get that, I may choose it anyway just to get the rationale of why the doctor says, no, don't choose it, right? Or yes, you should have chose this. So this is simply for learning and practice, okay? All right, here we go. You are the night shift respiratory therapist at a large regional hospital. You are called to the ER department to assess a patient complaining of dyspnea. Upon arrival, the patient appears anxious and diaphoretic. The resident MD asks you to perform an initial assessment. So what are all the things you want to assess in this initial assessment? Now remember, the patient is anxious and diaphoretic in the ER, short of breath, okay? And it's asking you, what do you want to do as an initial? Now, when you think about initial, guys, remember, some things are down the road. That don't mean it's wrong, but it's not an initial, right? All right. First one, general appearance. Do we want to get a general appearance? And everybody can just say yes or no, okay?
Yes.
All right. General appearance, boom. It says the patient is anxious. Physician agrees. You got the green check. Okay, good. What about allergies? Do we want to know anything about allergies on our initial assessment?
No.
No, okay. But I'm going to choose, now you're saying no, which might be right, but I'm going to choose it just to see, so you can see whether the physician agreed or not, okay? Allergies. Allergies said yes. Allergies, the patient is allergic to penicillin. Now, this is something that you want to ask them. Are you allergic to anything? That's important because you're about to start giving treatments, albuterol. You could be giving a lot of different meds. You need to know what the patient is allergic to, okay? So part of the initial, and I know you say, well, that's not really the respiratory, but in the initial assessment, you see the NBRC hospital wants you to see if they have allergies, okay? So that's important because they're allergic to penicillin. That's something good to know if we got to give an antibiotic or something, right? All right. What about breath sounds? Do we want to listen to her breath sounds?
Yes.
Okay, let's see. Let me see what they looking like. All right. Breath sounds are fine crackles throughout all lung fields. Remember, fine crackles. Okay. That should be put in your mind somewhere. All right. What about LOC, her level of consciousness? Do we want to assess her level of consciousness? Anybody? Anybody can say anything. You might be muted. Just unmute your mic if you're going to say something. Level of consciousness.
Yes.
Okay, yes. Let's see. All right, let's see what the level of consciousness. They are alert and oriented times 3. So she's alert, oriented, her breath sound. This is our history here, guys. So if you want to see what our history is, this is the same as the top question. General appearance is anxious, right? She's allergic to penicillin. She has fine crackles throughout all lung fields and alert and oriented. Now, on these simulations, I need you guys to respond. It don't matter if it's the same person, just anybody, because this is not to say it's not a right or wrong. This is just simply learning what and when to choose something in our information gathering and our decision making. Okay, it's just practice. What about, excuse me, skin assessment? Do we want to do a skin assessment, whether they're diaphoretic or dehydrated, things like that? Do we want to do a skin assessment?
Yes.
Yes. Okay, let's see. All right, skin assessment. Physician agrees. Cool to touch and diaphoretic. So the skin is cool. She's got like a cold, sweaty, and diaphoretic. Okay. What about cough? Do we want to assess her cough, whether it's productive or not?
Yes.
All right, cough. Physician agrees. It's a dry, non-productive cough. Okay, so we're working it up. What about pedal edema? Do we want to see if she has pedal edema?
Yes.
Yes, because she's a cardiac patient, right? We're thinking cardiac. So, yes, let's see if she's got pedal edema. Yes, +2 pitting edema in the ankles. +2 is probably, and that's, you look at that by sticking your finger on their ankles or their shin, right? You press down and see if you leave a pit. And I can't remember +1, +2. I think it goes up to 3, but +2 is pretty moderate, right? So she's swollen. MVV is a maximum ventilation. It's like a spirometry like test. MVV. Do we want to do an MVV?
No.
Okay, no. All right. Now I'm gonna click it just so, because sometimes they give you a rationale of why not to do it. Okay. MVV, but you guys said no. Okay, let's see what the doctor says. Right. The doctor says no as well. Okay. Physician disagrees. They didn't give us a reason, but physician disagrees. So maximum, I think is I gotta look back to see what the MVV is, but that's not nothing you want to do right now. That's not it. What about a medical history? Do we want to know her medical history?
Yes.
Yes. Medical history. Physician agrees. Oh, look at there. She has a history of orthopnea and hypertension. So in our mind, where are we thinking, guys, with the history of hypertension, orthopnea, and fine crackles and edema? What do we think she had?
CHF.
CHF. That's what I'm thinking, right? But we're just getting there. We're just trying to see. What about a EKG? Do we want to get an EKG on her?
Yes.
Okay, EKG. Let's see. Doctor agrees. She has sinus tachycardia with multifocal PVCs. Okay, what about a chest x-ray? Do we want to get a chest x-ray on her? Anybody want to do
Yes.
a chest x-ray?
Yes.
Yes, okay, let's see. Good. Diffuse bilateral fluffy infiltrates with cardiomegaly. So there again, bilateral fluffy infiltrates, history of hypertension and orthopnea, fine crackles in the lung bases, right? All these things, guys, are leading to our diagnosis. So you're doing great. What about a cardiac stress test? Do we need to do a cardiac stress test on our initial assessment?
No.
No, and I'm not even gonna pick it on it, because some of these I'm not gonna do, because it's no. Cardiac stress test, no, not at this time. That may be later, but not at initial. Remember, this is the initial assessment. So be careful when you're choosing those, because those will take you, if you do something that he or she doesn't agree with, that takes points away from you, right? What about SAT? Do we want to see what her SAT is?
Yes.
Always, yeah, always see what the SAT is. All right. She's 86% on 6 liters of oxygen. So say on 6 liters of oxygen, sat in 86%. She's short of breath, anxious, and diaphoretic. Keep that in mind. All right. What about a sweat chloride test?
No.
No. What is that for?
See, Cystic
Yeah.
fibrosis.
Cystic fibrosis. Good. So if somebody didn't know that, they might say, well, yeah, let me see. They did say she was diaphoretic. So let's do a sweat chloride test, right? It can happen, but no, you would be wrong. So yes, sweat chloride test we do not do. That is for cystic fibrosis. All right, good job, guys. That's your information gathering. Let's go to the next section. Based on your initial assessment, the resident asks for your recommendations. Now, this time you can choose as many as you want. Sometimes they may say choose only one, right? But based on our initial assessment, our simulation history, remember the patient is anxious, she is allergic to penicillin, breath sounds of fine crackles throughout the lung fields. She's alert and orienting times 3. Skin is cool to touch and diaphoretic. She has a dry, non-productive cough, +2 pitting edema in the ankles, right? MVV, we didn't get. The medical history, she has a history of hypertension and orthopnea. The EKG shows a sinus tact with multifocal PVCs, right? She has diffuse bilateral fluffy infiltrates with cardiomegaly, and she sat in 86% on 6 liters of oxygen. Now, based on this, the physician asked us for our recommendations. What do we recommend? So I'm just going to go down the list and you tell me yes or no. Now, remember, she's on 6 liters already, right? Sat in 86%. Now, do we want to put her on 2 liters oxygen cannula?
No.
No.
Huh?
No.
No. she's on 6 and already sat in 86, so no. Not going to do that. What about 5 liters of oxygen reservoir cannula?
No.
No.
No. What about 40% air entrainment mask?
No.
No, because remember 40% is about 4 or 5 liters of oxygen, right? Remember your rule of 4s when you're doing that, you're thinking in your mind. So if she already doesn't say she got COPD, doesn't say she's breathing fast, right? So no, that's not going to work either. What about a non-rebreather, 100% non-rebreather?
Yes.
Yes.
Yes, let's choose that. Let's see what the doctor says. Okay, we're going to do that one. A physician agrees. 100% non-rebreather mask. What about an 8-liter partial rebreather?
No.
No, we already got 100% non-rebreather. I'm not going to go to partial breather. What about morphine?
Yes.
Yes.
You saying yes? Let's see. Didn't say she's in pain, but remember we did say that morphine helps with your the hypoxia or make you forget that you're hypoxic. Let's just see in this situation what the doctor have agreed. Good. Gave a little morphine that helps calm them down and make them not think that they're hypoxic. Excellent job, guys. What about amoxicillin?
No.
No. Why and why not amoxicillin? Why not amoxicillin?
It's an antibiotic.
It's an antibiotic, and have they told us anything that make us think that she has a bacterial infection?
No.
What do we need to know if they have a bacterial infection?
White blood count.
Temperature.
Good. White blood count greater than 10,000, right? If they didn't tell us that, or what is somebody? I think somebody said fever. Doesn't say she has a fever. Doesn't say she's coughing up yellow or green sputum. It doesn't say she got a CBC and her white blood count was greater than 10,000, right? So you don't just, and it could be, right? She could have all these things, but they didn't tell us that. And since they didn't tell us that, we don't deal with it. So great job. No amoxicillin right at this time. What about some Lasix?
Yes.
Yes.
Yeah, let's hit her with a little Lasix because it says she had fine crackles, and pitting edema, right? So we need to get rid of some of that fluid. 20 milligrams IV Lasix was given. Doctor agrees. And then what about positive inotropic medication like digoxin?
Yes.
Yes, let's see. Good. Physician agrees. Excellent. That's all of them on that for treating. Now that's our treatment levels because we're thinking CHF, right? And so since we're thinking CHF, we know we give positive inotropic agents for CHF. We give Lasix for CHF, and we can give a little morphine to help with the hypoxia feeling that the patient is having, right? Great job. And we treat it with 100% oxygen. Perfect. Okay, next. All right, so the doctor agrees with all your recommendations, right? Several hours later, now they paid you again to come to the patient's room, stat. Okay, when you get there, the patient is not responsive to voice commands. Her respiratory rate is 8 breaths per minute with periods of apnea. She's sat in 79% on 100% non-rebreather. What is the most appropriate thing to do at this time? You can only choose one. So I'm gonna look at the list. Do we want to start on albuterol?
No.
No, nothing in here says nothing about albuterol. We passed that, right? What about intubate and put her on the vent?
No.
No.
Okay, you don't want to intubate. What about a stat portable chest x-ray?
No.
What about an ABG?
No.
And what about call the patient's doctor?
No.
And in a BiPAP?
Yes.
You thinking BiPAP? Okay. So the choices between this one, guys, is intubating or putting them on a BiPAP. Now look at the question. It says the patient is not responsive, and her respiratory rate is 8 breaths per minute. All right. So you have to know that there are certain indications that immediately put you into an intubation status. Okay. A respiratory rate of 8 or less, or greater than 30, right? For an issue like that, you want to intubate. So in this case, guys, she's sat in 79% on 100% non-rebreather. She's not responsive, okay? And her respiratory rate is 8 breaths per minute with periods of apnea. In this case, we have to intubate, okay? You have to intubate, guys, so don't be scared to do that. So NIPPV would be good if she was responsive. If she was still awake and saying, you know what, I'm still real short of breath, SATs are going down, and yeah, let's put her on NIPPV and see if we can push that fluid out, right? Maybe that's the problem. That would be a good choice. But what makes you go to intubation, guys, is simply because she is unresponsive. She's not responsive to your voice, and she's breathing 8 times a minute. It's time to intubate, okay? Everybody understand that?
Yes.
All right. You want physician agrees, intubate. Don't be scared to tube them, okay? If that patient is non-responsive, and there's other indications for ventilation, like I said, when we get to that, we'll go over some of those indications and contraindications. But anytime you see non-responsive, periods of apnea, sat in 79, she's over the moon. It's time to intubate. Okay. All right. So we intubated. Now, in this case, they want to know and we're almost done. In this case, they want to know what initial settings do you want to do. So the patient is intubated, placed on mechanical ventilation, right? The physician asks you to recommend ventilator settings. The patient is 172 centimeters, right? And 68 inches tall, right? Weighs 66 kilograms, which is 145 pounds. They want to know which of the following ventilator settings do we recommend. We can only choose one. Now, in this case, guys, I'm going to give you a trick for test taking on this. Anytime they give you a patient's height, you must do the ideal body weight calculation for ventilator settings. Okay? Anytime they give you the height. Now, if they give you the weight and they don't give you a height, then you just go by that weight. You make it into kilograms and then use that to do the formula or whatever and do it. But if they give you a height, then don't trust that the weight they give you is ideal. Okay? For instance, if somebody's ideal body weight is 65 kilograms, right? But they tell you the patient is actually 100 kilograms. Well, that means the patient's overweight, right? If their ideal body weight says they should be 68 kilograms, but the problem is telling you that they are 110 kilograms, don't go by the 110. Go by the ideal body weight. This is the concept that gets a lot of people on the test, okay? Now, in this case, we don't know if the weight that they give us is ideal for the height that she is. So write this down. I know you probably have a formula for ideal body weight, but I have an easy one. You might have an easy one as well. But just remember, ideal body weight when you're doing ventilation, trying to get a tidal volume, is 6 to 8 mLs per kilogram of ideal body weight. 6 to 8 milliliters per kilogram of ideal body weight. Now, to find ideal body weight, you write this down. For females, it's 105 plus 5 times however many inches over 60 they are. Okay? And that's going to give you pounds. And then you convert that to kilograms. And then you multiply the 6 and the 8 to get your tidal volume. Again, ideal body weight in females, 105 plus 5 times however many inches over 60 they are. Real easy, simple, fast way to do ideal body weight. Okay? Now, it may turn out that her ideal body weight is actually what they told us her weight is in the problem. It may not. So never trust it, because I promise you they're going to give you a height and a weight, and you're going to some people are going to just go with the weight that they give you and trust that it's ideal for her height. And it's usually never is. Okay? So let's see. Let's work this out together. Let me get my calculator. 105 plus 5 times however many inches over 60. Okay, so how many inches tall is she? She's 68 inches tall. So how many inches over 60 is that? Is 68?
8.
8. So that would be 105 plus 5 times 8. Okay, so 105, I'm sorry, 105 plus 5 times 8, right? So 5 times 8 is 40, right? And so that's 105 plus 40. So her ideal body weight is 145 pounds, right? And lo and behold, the problem was being honest. So it tells you she's 66 kilograms, 145 pounds. So they were being honest, but never trust them, guys. Never trust them. If they give you a height, I don't care if the patient is 1,000 pounds. If they give you a height, use the height, okay? And calculate that height on ideal body weight to do your initial settings. That's going to be right every time. All right, so 145, don't forget how to convert. How do we convert that to kilograms?
$145 divided by 2.2.
Good. 145 divided by 2.2. So let's do that. Which is, I guess comes out to 66, but I always want to do it myself. 145 divided by 2.2 is 65.9, which is 66 kilograms. Excellent. So 66 kilograms. Now we got to do 66 times 6 and 66 times 8 to get our range of tidal volume. All right? So 66 times 6 is 396. And then 66 times 8 is 528. All right. So her ideal body weight tidal volume range is 396 to 528. Now let's look at our choices. Now we're ready to look at our choices. The first choice says ACVC, rate of 12, 100%, tidal volume 750. Do we want to do that?
No.
No, tidal volume is way too high for her. Number 2, ACVC, a mandatory rate of 14, FiO2 of 100%, tidal volume of 500, and a PEEP of 5. What about that one?
Yes.
Yes.
Sounds good. Let's put a little circle by that one and look at the rest of them. What about number 3? It says AC ventilation, a mandatory rate of 8, FiO2 of 100%, and a tidal volume of 550.
No.
No, 2 reasons for that. The 550 is too high and the 8 is too low. We never do anybody on 8. We usually start around 12, right? Of when you're doing a rate on the initial setting. So that's out. All right, and then finally, AC, a rate of 12, 60%, and FiO2 of 550, and a PEEP of 6. Do we want to do that?
No.
No. So the best choice is the second one. 14,500, PEEP of 5. Physician agrees. See, that's how it works. Easy. Great job. Great job. And I'm telling you, just like they told us that the patient was 172 centimeters and then 68 inches tall and weighs 66 kilograms, they could have said she is 68 inches tall and weighs 150 kilograms, right? Which means she was simply overweight. But if we would have said the 150 kilograms and did our tidal volume, then we might have picked that 750, right? And thrown ourselves off. So that's why it's important. Anytime they give you the height, I can't say it enough. If they give you a height, it doesn't matter if they're 2,000 pounds. If they give you a height, use the height. Okay? Great job. Physician agrees. All right. So you put them on the vent, 12, 100%, 500, 5 a PEEP. A pulmonary artery catheter is placed, and the doctor asks you to confirm its correct placement. Remember, that's the pulmonary artery catheter. We stick it in, and it goes through the heart and rests at the pulmonary artery, testing for hypertension, right? Seeing if the patient has pulmonary hypertension. We're almost done, guys. And to confirm, the doctor wants us to confirm its placement. Now, after reviewing the chest x-ray, you note that the PAC catheter tip is in the right atrium. Which of the following recommendations would we want to make? Well, if it's in the right atrium, can you guys see me right now when I'm pointing at the heart as well?
Yes.
At the screen?
Yes.
Okay, good. So a pulmonary artery catheter is what was placed. But when you did an x-ray, you saw that the pulmonary artery catheter was at the tip of the right atrium. So which of the following recommendations do we need to do? We can only choose one. What do we need to do? Do we need to advance it to the left atrium?
No.
Okay. Do we need to withdraw it to the superior vena cava? Do we need to pull it out and come back up to the superior vena cava?
No.
No, because it's a pulmonary artery catheter, right? All right. The third choice says the PAC is in correct location. So with it being in the atrium, is it in the right spot?
No.
No. So the last thing says advance the PAC to the pulmonary artery. So we push it down and to the pulmonary artery. Is that what we want to do?
Yes.
Yes. See, step by step. So, okay, doc, we can get rid of all those other crazy choices and advance the PAC to the pulmonary artery. Physician agrees. All right. But if you don't know what a PAC, because they could have just said a PAC. They didn't have to say pulmonary artery catheter. We have to know that a PAC line is a pulmonary artery catheter. All right. And that's in your hemodynamics, which we'll come to soon. All right. Physician agrees. Bam. Last one. Several days have passed. The patient has improved significantly. The patient has tolerated spontaneous breathing trials with CPAP 5/5, right? Pressure support of 5, FiO2 of 35%. The ICU doctor asks you to determine, is the patient ready for extubation? So which of the following assessments do we want to get or determine to determine is this patient ready to extubate. Now, when we get to those ventilator indications, contraindications, and extubation indications and contraindications, right? You need to know those. What about let me get my paper. MIP is a maximum inspiratory pressure. That's how hard they can suck or generate a breath. Do we want to get that and see?
Yes.
Yes.
Yes. All right. It's negative 55. Excellent. Now remember, indications to put somebody on a vent is having a MIP less than negative 20. So less than negative 20 means they need to be on the vent. Hers is negative 55, so she's doing great. All right, good job. What about a vital capacity?
Yes.
Yes.
Yes. Let's get a vital capacity. I'm trying to see, find my number. Vital capacity. All right. Vital capacity is 2 liters. Remember, indications to put somebody on a vent is a vital capacity less than 2 times their tidal volume, right? So if her tidal volume is 500, then 2 times 500 is about 1,000, right? So as long as it's greater than 2 times their tidal volume, right, then we good. So hers is 2 liters. So that's much better than her tidal volume. So that's good. What about a tensilon challenge? Do we want to get a tensilon challenge?
No.
Okay, good. Now, no one, of course, a lot of people might not even remember or know what a tensilon challenge even is. So you can always look it up. But I believe a tensilon challenge is something we look to see if they have myasthenia gravis, right? That's something we do for myasthenia gravis patients. So tensilon challenge, no, we're not going to do that. But if you don't know that, then you may grab it thinking that's something you need to do. So terminology is important. Brush up on your key terms. So tensilon challenge, no. What about a spontaneous tidal volume? Do we want to see how good their spontaneous tidal volume is?
Yes.
Yes. 450. Looks good. What about a level of consciousness? Is that important?
Yes.
Yes. We don't want them to be knocked out, sleeping, can't wake up, right? So level of consciousness is good. The patient is awake and alert, times 3. What about an RSBI?
Yes.
Yes, let's get an RSBI, rapid shallow breathing index. RSBI is 70. Good. Now, I believe most things are RSBI less than 100 or less than 105 is okay, right? Or less than, some places are 80, some places say 100. It just depends on you. So we'll look to see exactly what the NBRC's cutoff is, but I believe it's 100, okay? But 70, excellent. And then finally, a MVV.
No.
Let me even, so I can tell you what that is. Okay, here we go. Yeah, the maximum voluntary ventilation. That's is a pulmonary function test measuring the maximum amount of air a person can breathe in and out, usually over 12 to 15 seconds, extrapolated into 1 minute. So you said no. So we're not going to do an MVV. That is something we'll do when we're doing just like a pulmonary function test for other reasons. But if they're already on the vent, we wouldn't want to do an MVV at that time. So good. Those are the things we chose. Let's move on. All right. ICU doctor asked for your recommendation based on your assessment. You will now recommend what? So after all that we just did, and here's our simulation here. I promise this is the last one. We got an MIP of negative 55. Her vital capacity is 2 liters, which is good. Spontaneous tidal volume is 450, good. Her level of conscience, awake and alert and oriented, times 3. RSBI of 70. What are we ready to do? Do we want to get an ABG?
No.
No.
No, we passed that. What about extubate?
Yes.
Yes.
Yes, let's get that tube out of it. The other thing says decrease the pressure support to 0, recheck an AB. No, you don't never do that. And then continue the spontaneous breathing trial. So just let her sit on the vent when she's ready to get off. No, we're going to extubate. Physician agrees. All right, let's look at our display our results. We passed. Information gathering was excellent. Our decision making was excellent. And our total was 94%. You saved Miss Johnson. So that's how it works, guys. That's how the simulations work. All right. So that is the end of this class. You guys did great. Sorry for going over 18 minutes over, but I wanted to make sure we got that in. Now, I did say on the next class we were going to get into some pediatrics, but we a little bit short for time today as far as the other stuff. So I want to finish the cardiac. So I'll be finishing the cardiac, which is, let's see, let's go back and let me show you where we are for cardiac. I'm going to share my screen just to show you where we will be on the next one before we get into peds. I want to make sure we finish the cardiac part. So let me share there. All right, let me go back here, back to simulations. Okay, dashboard. Get rid of that. All right, we were doing cardiac assessments. We got all the way down to cardiac pathophysiology. Make sure we did that. Yeah, CHF and all of that. Then cardiac assessment. Come on. All right. Yeah, so that's gonna be next. EKG. We're gonna look at the electrocardiogram. We're gonna start here on the next one. EKG equipment, talking about the equipment, the electrodes, the leads, all that kind of stuff. We'll look at that. Then we're going to do heart rhythm and recommendations. All right, we're going to go over our heart rhythm. So go ahead and be brushing up on those, as that's important. Knowing what the rhythms are, what they look like, right? We're going to do some practice EKGs, right? We're going to throw up some practice strips, and we're going to look at them and try to see if we can guess what they are, naming this EKG, right? Why does it keep doing that? Electrolytes, EKGs and electrolytes, how EKGs and electrolytes are very important in our function of depolarization and repolarization, right? And then finally, we'll take a little quiz with that and go into hemodynamics, which is my favorite. Hemodynamics is my favorite. So we may have the pediatric one might come after next Saturday, not this Saturday, but the next one. That way I want to make sure we get finished with cardiac, right? And then we'll move into pediatrics, and then we'll go into mechanical ventilation indications, contraindications, making changes on the vent. When do I make changes? And do practice tests on TMC about ventilator changes and plateau pressures, all that kind of stuff. Okay, so that's what you can expect on next Saturday. We're going to finish up where we left off, which I said was EKGs. All right, we're going to go into EKG equipment and rhythms and all of that. Okay, so let me stop my share again. Again, great job. I appreciate everybody. Once this gets through loading, I'm going to upload it to my YouTube page. That makes it, because it's easier for me to send the link to you on the YouTube page. That way you can I can text everybody the link to this video, and you can open it up and look at it and take what notes. And whoever missed this can go back and look at those notes and take notes so they can be caught up to where we are on next Saturday. Okay? Don't forget, go ahead and start thinking about when you're going to take this test. I should be able to tell you a little bit more of a schedule next week to say, okay, guys, I think we'll cover as much stuff as we're going to cover by this day, and that way you need to go ahead and be trying to schedule your test that week or the next week so it's fresh on your mind. Don't wait. Especially unless you want to, because you have graduated by the 7th. I'm gonna try to be at the graduated for those who are graduating this year. And so it'll be after that. But you need to go ahead and take that test as soon as possible while it's fresh from our classes, okay? If not, there's nothing else. I'll see you guys next Saturday at 1 p.m. And thank you for tuning in today. Have a good day.
Thank you.
You
You're
too.
welcome.